I will be discussing on a terminal chop technique, that is a new nuclear fragmentation technique, especially for the harder cataract. It was introduced and invented by Dr. Arvind Prasad sir, and it is best suited for medium to hard grade of cataract, and it reduces surgical time and chances of complication. And this technique was first published in IGO in 2016, and we are practicing this technique since 2013 when Dr. Prasad first described the same in a conference. So the principle behind this technique, that it is a technique used to create two halves of the nucleus without making any horizontal excursion. This technique typically explores Griffith's theory of brittle fracture. It creates a shallow groove with the specially designed chopper terminator and keep the chopper in a lateral position. And with both the chopper and phaco probe, a splitting force at 90 degrees is generated. And this is propagated from the equator to center and equator on the other side. And this force is working along the brittle lines, and inside out dispersive mechanical forces are used to create the crack. So this is a small video. So a small crack is created. You can see it's a very hard, big rock. This rock divides on the basis, so a crack is created. So we follow the Griffith's theory of brittle fracture. So in brief, first is the completion of capsular axis. Then a short superficial central trench of 1 into 1 into 1 mm size is created to hold and engage the phaco tip. Then the phaco settings are changed to high vacuum settings of 450 to 500 millimeter of Hg with 50 to 60% of power and 35 millimeter per minute of aspiration flow rate. Then the phaco tip is engaged at the distal end of the trench. Then the phaco probe is impaled, superficially keeping the tip directed towards the equator, parallel to the pupillary plane to achieve firm hold of the nucleus just within the equator. Then the equator is drawn within the capsulotomy edge, and under direct visualization, a wedge-shaped blunt olive tip chopper terminator is simply passed around the lens equator. Then the terminator is then simply dragged 1.5 to 2 millimeter through the open edge equator to create a small groove. And this dragging generates a tension and dispersive forces along the side of the groove, consonant to drag, pick, and rock excavation system, and initiates a full thickness nuclear crack. And this full thickness crack traverses automatically across the lens to the other end of the equator and divides the nucleus into two equal halves. So this is the spatial terminator chopper used in lateral position. And this is how it divides the nucleus into two heminuclei. So there are a few videos. Completion of rexes, main port entry, triplanar, side port, then the hydrodissection and delineation, coating of endothelia with HPMC. Now you can see this is the terminator chopper, grade 2 to 3 hard cataract. So it is holed, and now it is dragged outside the rexis margin, and now it's divided into two heminuclei and further division. So you can see it's just superficial impalement of the nucleus. It's not deep. Another video. Completion of rexis in the side port. And there is no chance of any trauma because the tip is blunt, as you can see in this video. Superficial, it is for holding, and then rest is with the help of the terminator chopper. Another video. Initiation of the capsular access. It's a deep-seated eyeball and the patient is uncooperative. So this technique can be done in these kind of patients also. You can see this is a terminator chopper. In a deep-seated eyeball, grade 2 to 3 hard nucleus. It is hold, it's out of the capsular access margin and divided into 2 heminuclei quite easily without any problem. And again, holding superficially, then dividing into further heminuclei. This is entry. This is the third video. You can see the golden ring. So it is sold superficially and with a very easy stroke, it is divided into 2 pieces, then further smaller pieces. So it's a very easy technique. So we have modified this technique. We are keeping the phaco-parameters in moderate range. And instead of using a spatial chopper terminator, simple chopper or dialer can also be used. And we have operated on all grades of cataract. And we have a prospective case sheet analysis from October 2016 to May 2021. And we have done more than 3,000 cases. And we have detailed data of 1156 cases. And nuclear grade was between 2 to 5. And they all were operated by a single surgeon. So these were the demographies and the other things. So the rate of complication is similar to any other technique. These were the results. The average total ultrasonic time was 1 minute 34 seconds, average phaco time 49 seconds, average torsional time 91 seconds, and average bottle height of 80 centimeters. So how it is different with other technique? Some say it is a modification of horizontal chop. No, it's a separate technique. It's a different technique. In terminal chop, the instruments tip move away from each other at the equator. And superficial impaled phaco probe is there in this technique. Whereas in the horizontal chop, the instrument tip move towards each other in horizontal plane at the equator. And the phaco probe is deep and it's towards the optic disc. In the vertical chop, the instrument tip moves toward each other in vertical plane, and the direction of the sharp chopper is towards the optic nerve. In terminal chop, it propagates the initial crack into a full thickness fracture in low compressive stress, whereas in horizontal chop, it creates a stressful compressive force, and in vertical chop, there is a shearing type of force is generated. And we have this study published also in IGO. And we have done a clinical trial on a comparison between the stop and chop technique in the direct chop versus the terminal chop, and it was presented in the previous ESCRS. So there are a lot of myth about this technique. Some say that it is a blind procedure, but we do every step is done under direct visualization only. And the chances of PCR are comparable. And the chances of endothelial cell loss and post-op edema, they are comparable or lesser. So we did this clinical trial between 3 types of chopping technique. So science can't be a myth or hearsay. It will always be a reality. And these were the results. So in every type of technique, there were more than 100 cases. And in the demography and the endothelial cell loss, the CCT change and the intra complications, there were no significant p-value difference in all the 3 techniques. Whereas when comparing the cumulative dissipation of energy and the total phaco time, there was a significant p-value of more than 0.005. So it has an advantage in terms of cumulative dissipation of energy and total phaco time. Thank you.
That's a very nice
presentation, and you have given such a beautiful data, and it's really pleasure to see your work on this technique. And any question from Dr. Arvind, Dr. Vinod.
Yeah, Dr. Arvind, what is the ideal size in this technique of capsulorhexis?
It should be 5.25 to 5.5, sir.
Any reason for keeping it low? If we keep it low or if we keep it higher, any problem with that?
Because when we are dealing with the softer cataract, means the grade 2 to 3, there is no problem. But when we are dealing with the grade 4 and the grade 5 nucleuses, then we need a proper axis size, because we need that superficial empalment of the nucleus at the equator, and it must come out through that capsular axis margin, because everything we need to done under direct visualization only.
Yeah. So bigger axis is preferably better if you want to start with this procedure, or for the beginners.
Yeah, for the beginners.
Yes.
In any case, like if you are dealing with the hard cataract, in any case, you have to make a little larger axis.
Definitely.
Whichever technique you use. If you have a larger axis, your manipulation becomes much easier. And put now, especially in terminal chop, like then your terminator, putting the terminator around the equator of the nucleus becomes much easier if you have a little larger axis. But as Arvind said, like if you have a little on the grade 2, grade 3, grade 4 kind of nucleus, a little softer also, then you don't need such a big axis. You can very well do this technique with a 5.25 or 5.5 millimeter axis also. So beautifully presented, Dr.